Good evening. I am going to present the next option. Dr. Rahul talked about the chimneys for the branches. Another option for revascularizing the branches is hybrid, which is mostly used for managing the arch and thoracoabdominal aortic aneurysms. So endovascular treatment of aneurysm is a welcome new option in the management of thoracoabdominal aneurysms. It carries relatively lower mortality and morbidity. Unlike standard TOR, visceral branches will be covered by the stent graft while treating thoracoabdominal aneurysms. Hence, the branches have to be bypassed extra anatomically before deploying the stent graft. So we have several options or several combinations we can take depending upon the anatomy of the aneurysm, which all branches have to be revascularized or debranched. There are some common points which are the inside or inflow sites for the bypass. Depending upon the extent of the involvement of the aorta, the inflow can be taken from the common iliac artery, the infrarenal aorta, the ascending aorta, or sometimes even from the descending thoracic aorta. And the anastomosis to the branches, the anastomosis can be done with variable combinations according to the number of branches to be bypassed and the convenience on the table. The anastomosis can be either an end-to-end anastomosis or an end-to-side. The origin of the bypassed arteries have to be suture closed to prevent an endoleak. I will first demonstrate a few cases we have done of the thoracoabdominal aneurysms, and then I will go to the arch aneurysms. Thoracoabdominal aneurysms are the most formidable surgical challenges because of the extensive nature and involvement of the visceral branches. Open surgical repair carries a high mortality and morbidity. Bleeding, paraplegia, and renal failure are the major complications. This is the first case I am going to demonstrate. There is a doctor who came with a thoracoabdominal aneurysm. You can see that that is the lower descending thoracic aorta. That's the celiac axis, renal artery. So it is involving all the four visceral branches, and it was extending down to the aortic lower abdominal aorta. So this is what we did. We have taken a bifurcation graft from the left common iliac artery, and this was anastomosed to the left renal artery. We didn't revascularize the celiac axis. The other end of the bifurcation graft was anastomosed to the superior mesenteric artery, and we used a side branch to revascularize the right renal artery. This is one of the options in this type of cases. You can just use the 16/8 bifurcation Dacron graft. This is one way of doing it. This is another case, a lady from Indonesia. Actually, she came for a bilateral knee replacement to India, but on investigation, she was found to have a huge, extensive thoracoabdominal aneurysm extending from the post-subclavian to the aortic bifurcation. So we had to do endovascular repair, and we had to revascularize the branches. Luckily for us, the right kidney is not functioning. You can see that right kidney is missing, and the right renal artery was closed. So we had to debranch the superior mesenteric, the celiac, and the left renal artery. That's the CT angiogram post-procedure, 3 months post-procedure. You can see that the stent graft starts from the subclavian, and this is from the left common iliac artery. You can see the one goes to the left renal artery and into the common hepatic artery, and the superior mesenteric artery is re-implanted into this branch of the bifurcation graft. So this is another option. You can either re-implant into the branch and then revascularize that. We usually prefer to anastomose to not to the main celiac axis because it's a very short, and not easily accessible, we usually anastomose to the common hepatic artery for revascularizing the celiac. Again, you can see that from the left common iliac artery, this branch of the bifurcation goes into the left kidney, and the other one goes to the hepatic artery, and the superior mesenteric artery is implanted into that graft. This is another example. You can take a bifurcation graft and you can make it a trifurcation, or even you can stitch another 2 branches to bypass more arteries. So this, we have made the trifurcation graft, and this is the anastomosis to the infrarenal aorta, and this will go into the left renal artery. This goes to the left renal artery, and this will go to the superior mesenteric, and this has gone into the. I'm just showing the way of any combinations of doing all these things. Now we go to the arch aneurysms. Again, there are so many options here. Depending upon the anatomy and the experience of the surgeon, you can debranch the arch. So it's a huge arch aneurysm. You can see such a huge aneurysm. 85-year-old gentleman who came with left recurrent laryngeal nerve and the left phrenic nerve palsy. So when we do the endovascular repair, we have to cover the left subclavian and the left common carotid artery. Here the option is a cervical carotid bypass, and if it's not important, we usually don't revascularize the subclavian artery. So what we did was, from the right common carotid to the left common carotid artery bypass, the left common carotid was proximally ligated, and the left subclavian was coil-embolized. And this is at the end of the procedure. You can see that the innominate, and from here, the left common carotid is being perfused. That's the end of the procedure angiogram. And there's a 3-month post-procedure CT angiogram. You can see that there is no endoleak. Our bifurcation, the carotid bypass is working well. The left common carotid is thrombosed, and the left subclavian is being perfused retrogradely. Another option, here the aneurysm is in between the left common carotid and the left subclavian artery, but if you want to get a good proximal landing zone, you have to cover all the 3 branches. So here, what you have to do is, from the ascending aorta, you have to take a bypass into the common carotid arteries. So for that, you have to do a midline sternotomy, take a bifurcation graft, and what we have done is, from the ascending aorta, we have taken a bifurcation graft, and we have anastomosed to the common carotid arteries in the neck. You can see the graft which is going into the neck, and this is the stent graft is coming into the proximal ascending aorta, just distal to the bifurcation graft. Another option for, again, similar type of case, another option is if you have enough space inside the thoracic cavity, you can do the distal anastomosis inside the thoracic cavity itself. This is a patient with a huge arch aneurysm with a dilatation of the ascending aorta. So we didn't want to actually replace the ascending aorta, or we didn't want to put the stent graft into the ascending aorta because that stent graft will have to be quite huge. So what we did is, in the beginning, from the ascending aorta, anastomosed the innominate artery, and the other branch into the left common carotid artery. But as I told you, the ascending aorta is quite dilated. It's a dilated ascending aorta. You cannot put a common stent graft there. So we did a wrapping of the ascending aorta to bring it down to the size where we can put a stent graft, a wide diaphragm graft was taken, the exact measurement was taken, how much you want the diameter of it to be, and then it was stitched to make it narrow. And you can see that's the bifurcation graft into the innominate and the left common carotid artery. That is the banded ascending aorta. And the stent graft was landed into that, and there is no endoleak. That's the post-procedure angiogram. To conclude, hybrid repair is a viable option in thoracoabdominal aortic aneurysms and arch aneurysms, especially in patients with high risk for open surgery. It carries considerably lower rates of mortality and morbidity compared to open surgery, but it requires an experienced cardiovascular surgeon to perform the debranching because it is not as simple as that, but it is less morbid than an open surgical procedure. The short and mid-term results are quite satisfactory. Thank you.
Thank you. Thank you, Neil. I have a question for you. These procedures are very complex, and thank you for reporting your good experience. Regarding the left subclavian artery, what is your personal policy about covering or not this artery?
If you are covering only the proximal descending thoracic aorta, you usually don't revascularize that. But if you have to cover the whole of the descending thoracic aorta, we need the subclavian branches to give collaterals to the spinal cord. Then we do a left carotid subclavian bypass. But usually we don't revascularize that.
Dr. Dietrich, you have a comment on this particular way to do or not? Micro, please. Microphone. Microphone, please. Microphone to the table on the right. Dr. Dietrich, what is your policy about this debranching?
Referring to the question of subclavian, when to do the subclavian bypass. Obviously, you've got to protect your posterior circulation. So if that's compromised, you have to do it. We're more inclined to do it if we have a situation where we're covering huge amounts of thoracic aorta, where there's compromise in the internal iliacs. But the percent of time that we do it prophylactically is probably less than 10%. So it's very uncommon for us.
Was there a question from
Mr.
the floor?
Chairman,
We are finished.
yeah, we'll have to
so
move
we
on to
go
the
on.
next. Yes. Thank you very much.